Welcome back. Today we're going to begin the study of the respiratory system, which again is a natural place to follow on the cardiovascular system. It's intimately connected in function and very close together in its physiology and structure as well. What we're going to do first is review the respiratory system as it affects the cardiovascular system, and then start where one doesn't normally think of the respiratory system, and that is at the lips and nose. The primary functions, the major role the respiratory system has, is in taking up oxygen for transport to the lungs, again the gas exchange that we talked about, to expel carbon dioxide, and to regulate that internal milieu, that homeostasis, keeping acid and base balance intact and at their very, very small limits of variation. It's very definitely a life support system. And just as in the cardiac and cardiovascular systems, we looked at the conducting vessels, and then we looked at distribution vessels, then we looked at exchange vessels in the capillaries. We have a very similar setup in the respiratory system. We have a series of tubes that are used for conduction of air, and then for distribution of air, and then finally for the exchange process. And they're all a little bit different. We start off really with the lips and the nose. This is where air conditioning is going to occur and regulation. In our evolutionary development, we had our digestive tract and our respiratory tract joined together. We can breathe through our nose, but we can also breathe through our mouth. And our airway comes together very closely with our digestive tract. If you look at the first slide, the biggest view, we see here the nasal cavity, which is much bigger than you think when you just look at the little openings of the nose. Very, very big cavity. And the mouth. They join together in the back, and they meet right here at the airway. But if you get a closer look at this, you will see that not only is the trachea and airway there, but right behind it we have the esophagus, which is where food goes down, and a place we'll study in a little bit. So we've got a little problem here in that we don't want any food going down into our airway. Let me back up and show you how the process begins right at the nose and mouth. We can take air in through our nose and through our mouth. This provides very, very good safety. It also provides backup. For example, if you had a completely obstructed nose, you can still open your mouth and take a deep breath. If your mouth were shut for some reason and you couldn't get any air in that way, you could use your nose. The problem is that, again, we have food going down and saliva going down part of our airway, and we have to make it go in the right place. Probably the reason we have this is for backup volume. For example, almost everybody sitting here has their mouths closed except for me, and they're breathing through their nose. They're in quiet respiration. Very easy to do, just the way it's designed. But you'll never see somebody running a marathon with their mouth closed. They have their mouth open, and actually auxiliary muscles of respiration you don't even think about. Neck muscles are pulling and opening up the airway. Their nostrils are flaring in many people in a visible manner to open up the nose wider. You can see that better in a horse, but it does happen in humans. So we've been provided with backup to allow a wider range of physiology for the stress situation, the fight and flight reaction that we need. There are actually some mammals that don't have that, and those are the water mammals. Both dolphins and whales have completely separated mouth and airway. They have their intake on the back of their head, which is what comes up above the surface of the water when they breathe, and they can continually take in water and nutrition through their mouth without ever being afraid of any connection. And in fact, one of the things that's a real no-no is to splash a dolphin or a whale on top of the water, because if they get water in that hole, they will get pneumonia. And just as a human being who accidentally aspirates, which means taking solid food into the airway, takes that food down into their lungs or water can also get pneumonia. So we've got some mechanisms to prevent that from happening. The first part of the airway is devoted to air conditioning, something that's really important. Again, when I go out of my house in January, one thing I don't want to do is breathe through my mouth. With temperatures below zero, humidity below 10%, the first thing that's going to happen to me is I will cough, because the airway does not want anything that cold and dry in it. So you immediately close your mouth and breathe slowly through your nose, which doesn't feel good for your nose, but feels very good for your lungs. If you look at this slide, inside, just inside the nasal passages, something you actually cannot see by looking in a mirror because they're further back, is a very big cavity that's lined with what's called mucous membranes. They're velvety tissue, richly supplied with blood, bleeds very easily when touched. This is where a lot of nosebleeds come from. And it has in it lots of redundant tissue heaped up in what are called turbinates or conchae. The turbinates, again, provide lots and lots of extra surface area by being redundant and wrinkled, and has a very, very rich blood supply so that air coming in over the turbinates can be warmed. Your body would like to have 98-degree air coming in terms of the way it feels inside, which is also 98 degrees. So the turbinate, which has the blood running right under the surface, has a way of conditioning the air and warming it up, at least to some extent, not necessarily all the way. The other thing it does is it's very, very moist. And that's why in cold weather, one of the things that you'll notice right away is you get a runny nose. It's the body's response to try to moisturize the air even more than it is. And that doesn't happen in very warm weather. So the turbinates will both warm and moisturize the air, and it has a third function. The mucus, as you all know, on the turbinates is very sticky. When it comes out of your nose, it's very clear that this is not just water. And it catches dust and particles of foreign bodies that can later be either brought into the throat and swallowed or blown out your nose, as happens when you sneeze. It gets rid of those foreign particles before they have a chance to get down in the airway. The nose does not like to have anything past it, and the lung will make sure that nothing gets past because it'll cough it back out again. This area is called the nasopharynx. Pharynx means a gulf or the throat of a living animal. And this is, as you can see, just a big enlarged area. That's the nasopharynx. In the back of the mouth, we have the oral pharynx, and these two join together in the back of the throat right here. Now, what's going to keep the food we swallow from going down the, quote, the wrong way? It happens to people like me who talk when we're eating, something we shouldn't do and nature didn't want us to do. In the very back of the throat, right here, not easily seen, is a piece of cartilage shown in blue. Cartilage is kind of the precursor to bone. It hasn't been calcified, it's flexible, but it's very rigid. Not as rigid as bone, but not as flaccid as soft tissue. And it's anchored right here at the tip of the arrow and angles up and back. And it's called the epiglottis. It's covered with mucous membrane also, just like the rest of the cavity is. When we swallow, what happens is the trachea, which is right here, here's the opening to the airway, which is in front of the esophagus, this little slit is the esophagus, rises up to meet the epiglottis. The epiglottis flaps back again because the tongue pushes it back and the food or water also push it back in its flexible state, and it makes the swallowed objects go back down into the esophagus and miss the opening to the trachea. This is really important. And again, you can defeat this by trying to talk, which requires breathing and opens that area, while at the same time you're swallowing. And then you'll cough because the lung doesn't want anything going down there that doesn't happen, that doesn't belong there. And that means just moisturized, warmed air. In the back of this area are some objects called the tonsils, which we're going to skip. Here's a pharyngeal tonsil. In my day, almost everybody had those removed. These are lymphatic tissue, kind of tissue we saw in the last lecture, but of a solid nature, not circulating, and they are protection from infection. We have the hypopharynx, which is the lowest portion of the pharynx. And finally, we get down to what is called the voice box, or the larynx. The larynx is a very small object whose sole function is to produce sound. Remember that the lips and the tongue, which is what we really associate with speech and song, are there to form the shapes of that sound. Without the lips and the tongue, we would not have discernible words. We just have noise. But the larynx is the one that forms the sound. It's the organ of sound production. It's in the middle of the neck, about halfway between the base of your neck and the clavicle. And it's right in the midline. This is a front view of the larynx. The bone at the very top, called the hyoid bone, is one that you can feel with difficulty. What we're all familiar with is this bone, which is the thyroid cartilage. Again, it's not real bone. It's mostly cartilage, has very little calcium in it. And it has this little notch called the thyroid notch. That's the Adam's apple that you see move up and down when we're swallowing, moves up when we swallow to bring the larynx right up against that epiglottis. It has inside some vocal folds, which I'm going to show you in just a moment. But what's important about this structure is not only its location in the neck, but its complexity. It's capable of extraordinary range of sounds. We are, again, like our heart, at the top of the evolutionary chain. In evolution, we can produce more sounds over a wider range than any animal on Earth. There are some that can produce higher and lower sounds, but we can do them all. There are even very few musical instruments that can compete with the range of the human voice. Some can, but not many. Down here, just for information we will study later, is the thyroid gland, which surrounds the trachea, the bottom part that's below the larynx. If you look at the backside of the larynx, something you don't get to see very often, you can see it's very complex. It has lots and lots of different bones and cartilages, as well as muscles and membranes surrounding it. The sounds which emit, probably with the exception of a Bronx cheer, are all modulated by our tongue and our lips. And this range can be a problem too, because it can often cause a great strain on the voice itself if overused. Because what we do to make this sound is we tighten what are called the vocal folds. Inside that box, which is what it truly is something called the vocal folds. We tend to call them vocal cords, and that's really not correct. A cord to me always seemed like the string on an instrument that was stretched tight but was able to vibrate freely in the air, having air on all sides of it. The vocal folds actually are not free form. They are in the middle of the trachea. This is the front of the patient, and this is the back of the patient. The reason these are always oriented this way is because when doctors put a mirror inside the back of your throat to look down, this is the way they're going to see it. So we look at our pictures the same way. We're looking from top to bottom. This is the vocal ligament. This is the tight cord-like structure that goes from front to back and attaches on this movable cartilage called the arytenoids, and has a fold of tissue going to the side of the larynx. This would be your normal resting position. This is the rima glottis, some word you can quickly forget. It just means the opening between the cords. As with a musical instrument, the tighter the tension on the cords, the higher the pitch. So as you stretch the cords tighter, the voice will get higher and higher and higher. Now, this is carried out by all these small muscles and nerves inside the larynx. They're called the intrinsic muscles, and they are able to tighten and modulate the chords. This is the way it looks when you're resting. You're breathing normally, you're not making any noise. There is enough room here for the air to get in and out without vibrating the cord. Now, if you then move to the next slide, here's the cord in forced inspiration. We're taking a deep breath in, and we need the widest amount of room. This is when the larynx is acting as an organ of respiration, not what we call phonation. The next look, the cords are tightly pulled together. There's a little slit of airway, and that's where the cords are during phonation, making sounds. They're pulled tight to varying tightnesses, and you're vibrating them. The slower the vibration, the deeper the voice. The higher the vibration, the faster, the higher the voice. So it's really cycles per second, just like on an instrument. Male hormones have an effect on these cords. They tend to make these thickened. And just as it is in your piano, the thicker strings are at the bottom of the piano scale in the bass, and the thinner strings are at the top. Thicker vocal cords make a lower, deeper voice. And finally, in this series, we look at this lateral view. This is the side view. Here's that arytenoid cartilage holding the cord, and this is the normal resting position from the side. Look at these muscles here. These are called the cricothyroid, because this cartilage is called the cricoid cartilage. This is the thyroid cartilage, which we've seen. And they go from here to here. And if you look in this one, from here to here. There's two leaves of it. What will happen when we contract that muscle? We pull the entire voice box down from this dotted line to here. In other words, we rock it forward on its axis and pull it down. Now, what happens is the cartilage here can't move very much. So the vocal cords are stretched. And this person is singing high C. That's what happens to get that extra little bit of stretch. This area of anatomy is of particular concern to surgeons because we get to operate in here a lot. We go after thyroid tumors and parathyroid tumors, which I'll show you later on. And there are all the nerves to this voice box are right there where we don't really want them to be. And we have to dissect around and take great care not to injure them. When we get into the position, for example, of having to take out a thyroid gland, which is right here, we have the nerve, which I'll show you later on, that runs up to the voice box right behind that. And another nerve coming down from the top that goes in right behind this lobe, which innervates that cricothyroid muscle. If you injure those, various things are going to happen. There was a famous opera singer in New York who was having her thyroid removed, and the surgeon accidentally cut her superior laryngeal nerve, which went to the cricothyroid muscle. What immediately happened to her was she began to talk like this because she couldn't maintain the tension during her phonation that's required for basic voice control. Patients who have this nerve cut tend to have lower voices, some like that, and they tend to have voice fatigue because at the end of the day, they're unable to maintain the tension. But worst of all for this woman was that she could no longer hit high C. That nerve is actually called by surgeons today the nerve of Galli-Curci because it ended her career. And we're all very careful when we're in there trying not to injure anybody's superior laryngeal nerve. The other thing that you have is the recurrent laryngeal nerve, which innervates everything else in the larynx. And when that is injured or cut, the vocal cord comes to the center initially, because it's paralyzed. And it's overcome by the pull of the other muscles in there. Eventually, it'll become more floppy and flaccid, and the patient becomes hoarse. And that's a permanent hoarseness because you've only got one cord giving you the phonation and the other one just flopping in the breeze. Very bad injury, one we take great care to avoid. And in fact, when taking out a thyroid, 3/4 of the operation is spent protecting those two nerves. And then the rest of it just removing the gland. These injuries, fortunately, are in good hands, are very, very rare, but it's something that nature doesn't do to us very often, but surgeons do. Let me talk a little bit about tracheostomies, because this is an area that we hear a lot about, and I've run into a number of people who think this is a really easy operation. They would love the opportunity to help someone out by doing a tracheostomy. This is a very bad idea. This operation is one of the most underrated operations in all of surgery. It's not the hardest, but it's very, very underrated as to how much trouble you can get in doing it. And this occurs because what some doctors, but mostly lay people, don't know is that there's two kinds of tracheostomies. There's an emergency tracheostomy and an elective one. When you have obstruction anywhere above the larynx on this slide, you could have a piece of meat stuck in the back of your throat. You could have cord paralysis. You could have any number of things that cause airway obstruction. One of the ways to get around that would be to make a hole down here, somewhere in the trachea, and bypass the oral pharynx, the nasopharynx, or the larynx. I had a young boy come in once with a dart, a rubber suction dart on which he had loaded a needle. And as he was blowing this dart, he took a deep breath first, and the dart came in, landed right behind his cords. Now, he was very lucky. The dart went all the way down to his trachea and stuck there. If it had hit his cords, both cords would have come together in spasm, and he would have died of airway obstruction. People who get a piece of meat, a pea, some solid object that happens to land on the cord and doesn't get coughed out, those cords will close. And you won't be able to get down there to get them. So the only answer would be a tracheotomy or tracheostomy, and I'll tell you the difference of those in just a second. The other time that can happen is something called epiglottitis. I showed you where the epiglottis was, protecting the airway. In very small children, that can become very, very swollen from viral illnesses, and their airway is so small it can shut it. And you cannot put an airway down. You have to do an immediate emergency tracheostomy. Difference between otomy and ostomy, which we'll talk about more later, is basically one implies semi-permanence. When you say ostomy, you mean you're going to put in an appliance and keep it open for a while. Otomy merely means opening it and then closing it. It implies closure. So we really do tracheostomies. An emergency tracheostomy is done right here. This is called the cricothyroid membrane or ligament. It's a thin membrane, and you can feel it. Every one of you can touch the top of your Adam's apple, slide down the bone, and there's a little indentation. It's right under the skin. You can feel the little give, and there's nothing between you and the trachea but your skin. So a doctor or somebody who's very brave out in the street could take a knife and poke it right through here, and then insert some kind of a tube to allow air in. Now, this sounds far more easy than it is. There's bleeding and coughing and struggling. This is not a good thing to do, but it occasionally is life-saving. I've had to do one in my whole career. That was on a 4-year-old child with epiglottitis in the hospital who stopped breathing because of the epiglottitis. The nurse handed me a knife. We made the hole, stuck a catheter, took him downstairs to the operating room. And lucky to get away with it at that. In the street, you probably have very little chance of getting away with it. Too many things can happen. If your knife comes out, your airway comes out, you now have bleeding into the trachea, more coughing, more spasm. It can go from bad to worse quickly. The elective tracheostomy is actually done way down here. This is at the very top of the trachea where it sticks into the neck, out of the chest, just above the little notch in your sternum. and we go here in the operating room. You cannot do this as an emergency. There are too many things in the way. There are muscles, there are fascial planes, there are vessels, and sometimes even the thyroid. You need lights, instruments, retractors, and a lot of experience. The reason we put it in here is because this one is too close to the cords. Remember, your anatomy right above here are the vocal folds. Now, if you leave a foreign body in here, you'll eventually get infection in the cords, and they will scar up, and the patient will have damaged cords. So we do this as an emergency. Then we move it down here where it can be left in as long as necessary and lifelong in some cases if it's needed. For example, people who get cancer of the larynx from smoking and excessive drinking can sometimes have their larynx removed. They lose their voice, and they have a permanent tracheostomy down here. And they have this esophageal voice that they learn to do by actually swallowing air, burping, and making sounds as the burped, expelled air comes out. That's the upper airway. This is where it all began, and now the physiology part of that is the lower airway. And we talk a great deal about the pleura and the pleural spaces, and I need to review that again with you. If you remember this slide from earlier on, we have both pleural spaces on the right and the left containing a lung and the pleural lining. This is the parietal pleura, the one that's against the wall, and here's the visceral pleura shining against the lung. It was the same as the pericardium. I want to go one more time over that, how that happened, because the way it happens in the heart, the way it happens in the lung, and the way it happens in the intestines is all the same. The embryology is really very important. And if you understand it now, I think you'll understand it very well when we get to the abdomen, and we can move on quickly. Once again, picture me standing in the closet, coffin, the small room, and blowing up a balloon. This time, though, I'm going to have someone back to back doing it with me because we have two lungs. And between us is the heart already in its pericardium. Now, as I'm sideways doing this, you're looking at me, so I'm the right lung. I blow up the balloon goes out and hits the wall of the room I'm in and presses against it. It becomes very thick and tough. It is the parietal pleura. Parietes meaning wall. But as I keep blowing, the part near my mouth is going to start to expand and press against my face and my body because it has no place else to go, and it will line me in a very thin layer. That's the visceral pleura. That's the part that was in the heart, what we call the epicardium. The part that was stuck to the heart that we couldn't peel off. Same thing happens in the lungs. It becomes stuck to the lungs. It's the shining surface. And if you try to tear that off, you tear the lung. The thicker part is the outer pleura that maintains the integrity of the pleural space. And you might even think of what happens to the two parts that meet behind me. After all, the balloons are going to come together directly behind me. There's actually a ligament there called the inferior pulmonary ligament, and medical students have to find that in the cadavers just to show where it is. It doesn't have a lot of clinical significance, but it's part of the embryology. So that's the contained space. Now, in the pericardium, there was fluid lubricating the sac. The same thing happens in the pleura. This is not a real space. The artist here is indicating more of a space than we actually have. The space is only a potential space. Inside of it is a lubricating fluid, which is renewed, and that lubricating fluid allows the lung to expand and close with relative ease. I'm going to come back at a certain point and talk about some of the things that can happen here. But what we need to know now is that this structure, again, is conduction, distribution, and exchange, just like the vessels. If we look at a slide of the whole system again, we can see that our conducting system is going to be composed of first the trachea. We leave the larynx out of this because that's phonation, voice production. The next segment is the trachea. The trachea is made of soft, pliable cartilage rings, which are depicted here as dark, and little membranes in between. It's roughly circular, although it tends to be flat on the backside. And it is a conduction airway that has no function at all in exchange. It just brings the air to the lungs. And then it divides on the two sides, and the exact spot where it divides is called the carina, and the carina just is the Y-shaped position of this area. And finally, it goes into a right and a left main stem bronchus. The main stem bronchi, which is plural, are, again, conducting airways. They only bring the air to the right and left side. They divide sequentially into smaller and smaller segmental bronchi, and the whole thing is known as the tracheobronchial tree. And in fact, if you turn this upside down like this, you'll see that it looks like a tree with many, many branches. Now you can see in this slide the divisions. Here's the first of 3 divisions of the bronchi, from the main stem to segmental bronchi, and then into smaller and smaller ones. And actually, doctors have to learn every single one of these by name. They're very consistent, because at some point you have to look inside here. In the old days with a steel instrument, today with a flexible instrument, and you can look up into any one of these, getting down into very small divisions, and see any pathology or problems going on, sometimes correct those problems. So this anatomy is extremely important to physicians. The lung itself, after the divisions of the bronchi are understood, divides itself into lobes. And the lobes of the lung are something else we pay a great deal of attention to. These 2 lungs have been taken out of the body and are being looked at from the side. So if I go over to this statue and remove these lungs, what you're seeing is what you would have seen on the side of the whole lung here. This is the front, and then there's a back section, and this represents the vessels going in, the veins coming back out, and the bronchi themselves. The lungs are not hollow. We think of them as balloons, but they're not. They are much more like a very, very fine sponge, and I'll show you why that has to be. The lungs are divided into 3 lobes, although it doesn't look it here. We have an upper lobe here, or a superior lobe. We have a middle lobe here, and we have a lower or inferior lobe. On the left side, this is called a fissure. The little creases that separate these lobes, embryologically, the fissure between the upper and the middle lobe on the left disappeared somewhere back in time. I don't know why. I don't know why that was an advantage. I have to think it was an advantage, but I can't tell you the answer to that. So the upper or superior and middle lobes are combined on the left side. That's the only difference. And there are impressions in that lobe. When you take them out, you can see where the heart sits and where the aorta sits and where other structures pass right on through. The lobes are also divided into smaller segments, and those segments are named by the bronchi that go to them. So in the tracheobronchial tree, we looked at the segments, and if we look again at this picture, we will see that each of these has a segment to which it supplies air. And we look at them, and when we would write about them, we would write a report based on a normal trachea, primary bronchi, secondary, and so on, down to the bronchioles. We can't actually get any instruments down that far, but we have other ways to look at it. From a practical point of view, it's actually much easier to remove a lobe or a lobule than it is to get down to the small sections. If, for example, somebody had a cancer out here, this lobe is fed by 1 or 2 main vessels, drained by 1 or 2 main vessels, and has its air supply in 1 or 2 main airways. So we go in between here, dissect our way in. We only have a few things we have to take care of to get that out. Same thing with the lung itself. If you go in and you just cut the main stem bronchus here, sew it up or staple it, which is what is done today. Staple across the two big vessels, the pulmonary artery and vein. You can take this entire lung out very quickly and with very little difficulty technically than it would be to cut just, for example, this upper segment right here. Because here we'd have dozens and dozens of little vessels, bronchioles, and veins that we would have to look at to get out. This is done in surgery usually for cancer, some patients with emphysema, some patients with infection. The problem is there's another trap. Patients who have these diseases, emphysema, lung cancer, and many infections, are heavy smokers. They have destroyed much of the reserve of their lungs, and they don't have the reserve that a normal healthy person has. I could take a whole lung out of the average healthy non-smoking person, and they'd get along great on that other lung. They wouldn't have much trouble. But if the other lung is also damaged, they're going to have a lot of trouble breathing, and they may become pulmonary cripples, unable to do much but sit around and walk and trail behind them an oxygen tank, which I'm sure you've all seen. So dealing with the diseases here has this inherent trap. The people who need the surgery are the ones who can't always have it. They won't survive. We get then through all the conducting systems, and that brings us to the exchange area. We talked about it on the capillary side. We need to talk about it now on the pulmonary side. The alveoli, and the singular is alveolus, is the exchange portion of the lung. These are tiny microscopic air sacs. Once you get below the level of the bronchiole, we're talking about microscopic disease. So if we come down and look where we are, and look at the similarity between this and the vascular system. We get down into terminal bronchioles, the way we got down into arterioles, and look what we have. Lots of smooth muscle surrounding it again. We didn't have that up in the higher portions of the bronchial tree. We had cartilage. You can't constrict your trachea or your main stem bronchus. But down here you can. The cartilage is gone. This is a thick wall, but it has fibers that can direct flow into different areas. We have smooth muscle right down at the beginning of every alveolar group. It's a sac just like a bunch of grapes. And each of these little sacs carries air. Now, when the air is forced in here, don't forget at the same time, the vessels that are coming along here, the pulmonary artery and vein that have now broken down into arterioles and venules, are going to spread out like a net all over the alveolus. And this net is where exchange takes place. Carbon dioxide is going to leave the blood and go into the alveolus. Oxygen is going to go back into the blood, and we're going to have oxygenated blood going back, while venous blood is going to carry the carbon dioxide, okay, for disposal in the alveolus. There's your exchange. And it all happens in the alveolar sac. In some diseases, this sac, which has many little compartments so that it can have many little vessels, will break down its walls. Emphysema is a disease where these walls break down, and this, instead of being 9 or 10 little sacs, becomes one big one like a balloon. And it becomes flaccid like an overinflated balloon, and it has very poor exchange because it's lost too many of its convolutions and its vessels. And these big sacs in the emphysematous patient are not good for exchanging oxygen and carbon dioxide, and these patients have a lot of trouble breathing, and it is not possible to repair. Once they have this problem, they have this problem forever. The gas passes through with relative ease because of the thin walls. It looks like a sponge when you pick it up in your hand. If you take a cut section of a lung in your hands, you're not looking at a balloon. You squeeze it and tiny little bubbles will come out just the way it would in a kitchen sponge. But the sponge is very, very fine. The oxygenated blood will then go back to the heart and be recirculated. What happens next is that we need to move from this area and understand just two definitions which you're going to hear a lot, and that's the difference between ventilation and respiration. We talk about pulmonary ventilation. Now that you've heard them both, and I've talked about conduits and pathways, when we speak of ventilation, we're talking about the movement of air. When we talk about respiration, we're talking primarily about exchange. Now, respiration occurs here. It's going to occur as we take the freshly oxygenated air and put it into our arterial blood for the rest of the body, so it can go back through the heart, through the pulmonary veins, and then out through the arteries to the arterial blood in the rest of the body. But there's also cellular respiration. We're going to talk about that a little bit later. Right here, we're just worried about exchange respiration. We have some problems with this smooth muscle band. If you look at these muscles right here, just at the opening to the alveolus, they can contract. In their normal state, they're all open. And while you're breathing quietly, these remain open for good, easy exchange. If one of these closes down, we can sometimes use the muscles, the force of our muscles of respiration, our diaphragm and our chest, to force air past these constricted, smooth muscle bands, but we may not be able to get them out, and the lung can get overinflated. This happens, one common example is asthma. Patients with asthma who are susceptible to certain allergenic substances, foreign bodies, fumes, or other conditions can have abnormal sensitivity in these muscles, and they constrict. The asthma patient has more trouble getting the air out than in. But once the air is in, then it doesn't matter. If it's being trapped, it's going to have trouble getting the air in or out. Their very common symptom in early stages of asthma is the wheezing. The wheezing is merely the air trying to rush through the narrowed segment. That's the segment that is very much like the murmur you hear when you have turbulent flow in a heart problem or in a vessel that's narrowed. You will get turbulent flow and it'll make noise. Same thing happens here in the bronchiole. You'll get wheezing. The body also doesn't really like to see anything in there that shouldn't be there, especially at the level of the alveolus. Very susceptible to infections. We get things called pulmonary edema, where we can get fluid in the lungs. And really the guardians are higher up. The trachea and the bronchus, both bronchi, are lined with a single layer of cells that have hair-like particles on them. I'll show you these later on. And they beat upward like fields of wheat waving in the breeze. And when particles come down into there, smoke, soot, dust, pollen, they beat upward and they try to eject the particles and get it up into your throat, where you can cough them out into the back of your mouth, and they can either be swallowed or spit out. When you injure those cells, for example, again, if you're a smoker or if you breathe polluted air, the first thing that happens is those cells lose their hairs. They lose the ability to beat upward and to get rid of the particles that you want to get rid of. So it's a vicious cycle. Now somebody who's damaged their lungs by smoking, normally, or by being a miner who works in a polluted environment without a mask, they need to get rid of those particles which have damaged their lungs, but they can't get rid of them because the cilia aren't beating. Cilia means hair cells. And so those particles will stay there longer and do further damage. Whatever smoke they smoke will do further damage, and it's a very vicious cycle until we have things like emphysema, lung cancer, and other pulmonary diseases that will ultimately kill the patient. So think of this whole massive system as one of air conditioning for your lungs, of protection for your lungs, and for exchange. Much of the mass is mainly for conduction, some of it for respiration and exchange. Next time we'll go into the physiology of the gases and how this exchange occurs and is regulated.